We generally throughout each day get a mixture of patients with minor illness and minor injury coming in, and then the more majors aspect of things where people actually need extensive investigation, and then through to resuscitation. Routinely all three areas are busy throughout the 24-hour period, and our fantastic team works really closely to manage all of those cases. We've got processes in place, but we also flex our staffing and our processes in order to support each of those three areas depending on where the demand is. So there are two main routes of entry into an A&E department. That's probably the first place to start. There's the entrance that most people see, which is the walking entrance, whereby you come through the door into the reception area, you're greeted by the receptionist, and then you go through a process called triage, where one of the nursing team will assess you, find out what condition it is you've presented with and what investigations are likely to be required, and then stream you through to the appropriate area. The other mode of entry into A&E is via an ambulance and coming in through a different entrance round the back, which is closer to the majors and resuscitation areas. So from each of those processes, patients are streamed into the minors area, which is things like sprained ankles, coughs, colds, earache, those sorts of things. And they typically will be seen by either one of our middle grade doctors or one of our advanced nurse practitioners, who is able to manage that condition. And most of that group of patients go home, although occasionally we do need to admit some of the minors group. There's then the majors patients, so imagine you come in with tummy ache, you come in with chest pain, and those patients are assessed in the majors area. Those are patients who typically will need some treatment in terms of painkillers, in terms of fluids through a drip, but also will need slightly more investigation, so blood tests, x-rays, ECGs. And then finally we have the resus area, which is where patients who are acutely unwell are taken for active resuscitation. So that would involve normally them being seen by a senior doctor and a nurse working together in order to provide them with timely, efficient care. As I've explained, there are different modes of entry to the emergency department, and those are audiovisually separate for very good reason, in that if you come in with a minor ailment, you don't particularly want to see patients being rushed through for resuscitation. However, if there is a wait in the waiting area and it doesn't seem particularly busy, I just ask people to be mindful of what's going on beyond the door. So although the minor stream may be relatively calm, we can have large amounts of kind of active resuscitation ongoing, which people can't see. And obviously, if there are people coming in critically ill who need timely management, we will pull the doctors from the minors area to provide those life-saving interventions. And that can sometimes mean that although it looks relatively quiet in the waiting room, there's a lot going on, and our doctors are just busy elsewhere in the department saving lives.